Dr. Ryan here, specialist internist. Hope you and your family are well. Thanks for joining me in yet another video in the physician examination series. We're talking about secondary hypertension and how to approach this clinically. If you haven't yet subscribed to my channel, I strongly encourage you to do so. Alright, so how do we approach examination of a patient who has refractory or secondary hypertension? So as usual, step back and just have a look at the gestalt of the case. Introduce yourself, position the patient, and obtain adequate exposure, right? Let's just get my pointer in there. Then, look at the general appearance of the patient. Do they look azytemic? Do they look like they have Kussmaul's respiration, right? Do they look in respiratory distress? Do they appear Cushingoid, where we look for the buffalo hump, the wound faces, the dorsocervical fat pad, the lemon on a stick appearance, right? Or do they look acromegalic with the typical coarse facial features, with the spade-like hands, with the large feet, right? With the prognathism, right? Is there any upper body hypertrophy, which may allude to coarctation, all right? Then you go through and examine the radial pulses. You check for radiofemoral delay, which speaks to coarctation, as well as radial delay, which may speak to pulse inequality or subclavian steal. Are there any xanthomata, any fistula for dialysis, which probably implies target organ damage from the hypertension? Then, with the patient, supine, you want to also go up to the forearms and the arms and check the blood pressure, both lying and standing, or else you may miss postural hypotension. Right, take the blood pressure in both arms and in the thigh with a large cuff, especially if you suspect coarctation. Okay. Moving up to the neck, check the carotid pulse, palpate the vessel wall, check for the carotid bruit. At the same time, check if there's a goiter and if there's a bruit overlying the goiter, which probably speaks to hypervascularity of the gland, most commonly in Graves, which is a secondary cause of hypertension. Work your way up into the eyes, check for xanthelasmata, which speaks to arcocinilis and dyslipidemia, and the fundi for the hypertensive changes or retinopathy. Okay. Then when you come down to the precordium, you check out the apex beat. Is it a heaving apex beat, which typically happens in pressure overloaded states, notably systemic hypertension, aortic stenosis. Listen for a louder component of the second heart sound, a loud aortic component of the second heart sound, which probably speaks to hypertensive heart disease. Is there a fourth heart sound speaking to, a very a left ventricle which cannot relax very well, right? So poorly compliant left ventricle. Is there a systolic bruit, which indicates coarctation? Move down to the abdomen, listen for a renal bruit, palpate and blot those kidneys, especially if they're enlarged, because remember there's a big differential for enlarged kidneys, but polycystic kidneys should be probably one of the foremost differentials, especially in the setting of secondary hypertension. Aortic aneurysm, pheochromocytoma, okay? Femoral bruit, which speaks to peripheral vascular disease. Is there any proximal weakness? There's a whole host of causes of proximal weakness, but just to mention, Cushing's and Conn's syndrome is one of the foremost in terms of your endocrine perspective, especially if you're looking at this in the context of secondary hypertension. Distal sensory loss, speaking to alcohol and diabetes, and lastly, the urinalysis, okay? So guys, how do we stratify causes of secondary hypertension? By and large, there's vascular, endocrine, toxic, and others. Vascular, we're looking at renal artery stenosis, so it's important to listen for your renal bruit, right? Coarctation of the aorta, and we spoke to the radial delay, the radiofemoral delay, vasculitis as well. So look for possible causes of secondary vasculitis, especially your rheumatological conditions, systemic lupus erythematosus, rheumatoid arthritis, etc., as well as your vasculitides. You got your large, medium, and small, right? Endocrine issues, hyperthyroidism we spoke to, monocorticoid excess, right? Hypothyroidism, hypercalcemia, Cushing's acromegaly fail. Many of them have certain diagnostic features clinically, the so-called diagnostic facies, which one needs to be on the lookout for. Toxins in the way of corticosteroids can cause it. Non-steroidals can cause secondary hypertension, because remember, non-steroidals cause often arteriolar vasoconstriction. Okay, estrogen can cause it, sympathomimetics, alcohol, cocaine, amphetamines. Yet other causes are renal parenchymal disease, obstructive sleep apnea, especially in the setting of Pickwickian syndrome and obesity, white coat hypertension, pregnancy association. In a woman of childbearing age, always do your preg test, inquire about previous menses, etc. And of course, neurological disease, especially in the setting of Cushing's triad, bradycardia, hypertension, autoimmune mutation. We know those deals right there. When breaking down hypertension, we divide it into idiopathic or primary, right, which is 95% of the time we have that, and secondary. And then how we can investigate someone in whom we suspect secondary hypertension. So normally you just examine and do your renal panel. So it's split into 4 causes this way: abnormal creatinine, abnormal electrolytes, obesity or weight gain, and others. So abnormal creatinine, like you look for, you do your urea electrolytes, establish your estimated GFR, and consider your urine dipstick and 24-hour urine collection, especially if you're sitting in the nephrotic range. Or if you're considering nephritic syndrome, you look for red cell casts. Renal artery stenosis, good idea to do an ultrasound. And you find discrepant kidney sizes, you can then go on to a renal venogram. Abnormal electrolytes, think about hyperaldosteronism, which is otherwise called Conn's syndrome. So you want to do your aldosterone to renin ratio. Okay, in the patient who's obese or has a history of weight gain, always exclude pregnancy. And then you want to investigate for Cushing's syndrome, check for sleep apnea, hypothyroidism, so your thyroid function test, your sleep studies, your 24-hour urine cortisol, and then you go on to the dexamethasone suppression test, standard high dose, standard low dose, and standard high dose, and with a view to imaging thereafter. And then other issues talk about renal artery stenosis, fail, aortic coarctation, hypothyroidism, drugs. You investigate those appropriately, right? I hope you allow me to just speak about the spirit of sacrifice. The Lord is looking for men and women nowadays to build His church who have the spirit of sacrifice. And this is epitomized by the example of David in 2 Samuel 24, verse 24. We read that David came to the threshing floor of Araunah, right? And he had a burden in his heart that was given to him by the Lord to build the temple of the Lord. And so he wanted this piece of land, and Araunah actually offered the land to David free of charge. But look at David's response in this particular verse. But the king replied to Araunah, saying, I will not sacrifice to the Lord my God burnt offerings that cost me nothing. There must be a spirit of sacrifice in the heart and lives of those who are intent on building the true church, right? We cannot give simply out of convenience. It must cost us something, because that is the spirit in which God sent His Son to die on the cross for us, for the remission of our sins, so that we are forgiven of sins and born to eternal life. I pray that we will have a spirit of sacrifice in service unto God. Have yourself a fantastic day. I'll see you soon with another physician examination video. Take care.